Chavez, you have just presented the 3-year follow-up from the Zuma-12 study here at ASH in San Diego. Could you please give us a short summary of the most important findings from this study?
Thank you very much. My name is Julio Chavez. I'm from the Moffitt Cancer Center. I was very pleased to present the 3-year follow-up of the Zuma-12 study as a first-line regimen for high-risk diffuse large B-cell lymphoma. So the Zuma-12 was designed to address the question of whether we can improve outcomes of patients with high risk. In the study, that was defined as a patient with IPS score of 3 and 5, and also a patient with double-hit lymphoma, meaning like a MYC, BCL2, and or BCL6 rearrangement. So those patients were included. In addition, there was a disease risk assessment based on a PET scan. So patients had to get a PET scan positive after 2 cycles of standard chemoimmunotherapy. The definition of PET positive disease was based on the double criteria 4 and 5. So once the patients met the inclusion criteria, they were enrolled, they had apheresis, and then after completion of the manufacturing period, which was about 14 days, patients were treated with a standard lymphodepleting chemotherapy, with a standard for Axi-cel, that was followed by a single infusion of Axi-cel on day 0. The primary endpoint of the study was complete response, but there were also key secondary endpoints such as PFS, EFS, and overall survival and safety. So the study enrolled 40 patients, but 37 patients were evaluable for efficacy, basically because they had to be centrally confirmed double-hit lymphoma and or IPS score of 3 to 5. So in this case, the primary analysis was presented 2 years ago, and here we're presenting the 3-year follow-up or a median follow-up of 40 months. So we saw impressive responses with an overall response rate of over 90% and CR rates of 84%. And the survival outcomes were also significantly good, like the duration of response, event-free survival, PFS, and OS were not reached. The 3-year progression-free survival was 75%, and the 3-year overall survival was 81%. In terms of safety, there were no new safety signals in the study. There were no new cases of CRS or neurotoxicity. There were still some toxicities related to infections, but no patients died from infection except one patient who died of COVID. There were no second myeloid malignancies on the study, and all the deaths were due to progressive disease.
What are the clinical implications of this study?
I think even though we recognize that it's not practice changing, but it addressed the question of high-risk large B-cell lymphoma that usually are neglected from frontline studies. I think one of the most important clinical questions is that it supports the rationale to proceed with a large study, phase 3 randomized clinical trial, comparing actually a standard chemoimmunotherapy versus Yescarta and ciloleucel in the frontline setting. So that study is open and currently enrolling, and it's called the Zuma-23.
And last question, there was a lot of questions today after your presentation. Are there any of them that you want to highlight and tell us about?
Yeah, I think there are 2 questions I want to highlight. The first question was why not polatuzumab CHP, which is currently it was a positive study with improvement in EFS and PFS in comparison to R-CHOP in diffuse large B-cell lymphoma. However, the patient population in the Polaris study was very heterogeneous. IPI 2 through 5. The vast majority of patients were like IPI 3, no IPI 4 or 5. So in this case, the Zuma-23 is focusing on the patients who are IPI 4 and 5, which were like about 20% patients on the Polaris study. So it's different patient population that we're addressing this question. We're focusing especially on the high-risk patients. The second question that was always interesting at this coming up at ASH is the T-cell malignancies after CAR-T. We still don't know what the nature of this complication is. Unfortunately, that some patients develop T-cell malignancies. I think we have to be cautious and make sure that we do what is best for for our patients. I don't think it's going to stop enrolling the study. I think we'll continue. I think we have to study whether this is related to immunosuppression. Probably most heavily treated patients had developed these T-cell malignancies. So there's still a lot of unknowns about this. So I think we need to proceed to continue to move forward the CAR-T-cell or the cell therapy space, and one way is to move CAR-T-cell into the front line if it's possible.